Hey nurses, I know a lot of you listening work in critical care, the ER, or other acute care settings, places where emergencies can unfold at any moment. If you've ever wished you felt more equipped to handle those situations, or if you're already experienced but want to take your skills to the next level, then you need to check out the fall cohort of Rapid Response Academy. This is a 10-week high-impact training program built for nurses like you. You'll master the science, like advanced pathophysiology, critical thinking, evidence-based interventions for shock, sepsis, cardiac arrest, strokes, respiratory failure. But just as importantly, you'll strengthen the softer skills that often make or break a crisis, leading with calm in the chaos, advocating for your patient, navigating those tough conversations with the interdisciplinary team. So whether you're a brand new nurse finding your footing or a seasoned nurse ready to refine your expertise, Rapid Response Academy will give you the confidence and clinical edge to thrive when pressure is the highest. Pre-sales start October 6th, and we kick off our first meetup of our 10-week course Friday, October 17th. To learn more, I put a link in the show notes for you.
And then all of a sudden, she goes from a blood pressure of 130 to 98/69 at 1630, and in 7 minutes, she's 64/55.
Ooh, that was fast.
Is her blood pressure.
Okay.
Real fast, right? This is literally while they're doing their first attempt at a pigtail chest tube. A great rush of air on the first attempt. They put it in, they hook it up to suction, go get a chest x-ray, and the lung's still down. The pigtail's placed in the, essentially like her lateral chest wall. So they need to get another chest tube. So I come into the room while they're attempting their second chest tube placement. And I look up on the screen and I see a blood pressure of 57/33 with a heart rate of 50. And they're starting Levophed for her hypotension now. And I had lots and lots and lots of questions.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome back to the Rapid Response Run podcast. Today we're talking about one of those high-stakes situations in trauma care, and that is pneumothorax. I love the phrase, every trauma has a pneumothorax until proven otherwise, because it's one of those diagnoses where you don't want to miss it. It's a very easily reversible form of shock, but you can't treat it until you recognize it. So joining me today to help break down all the nuts and bolts of managing a patient with a pneumothorax is Peter. He's a trauma core team nurse who brings a ton of experience managing these patients on the front lines. We're going to use one of his most recent cases as a framework to break down the assessment, diagnostic strategies, interventions like needle decompression and chest tube placement, and the nurse's role every step of the way. And by the end of this episode, I hope that you'll feel more comfortable identifying those subtle signs of pneumothorax, know the steps to take and in what order, and feel confident carrying out the specific nursing task surrounding decompressing the chest. So Peter, welcome to the podcast.
Great to be here.
Yeah, so glad to have you. Thanks for reaching out. So Peter has a really good case that I look forward to talking about. But before we dive into this case, can you just introduce yourself and how did you end up as a core trauma nurse?
So my name is Peter Gradziak. I'm out of Eastern Pennsylvania. Notably to a lot of my colleagues, I'm known as Trauma Pete.
I love it.
And I'm not quite sure where that when you answer the phone and you go, trauma, it's Pete. And before you know it, everybody's introducing you to the new residents, the new nursing student says, hey, this is Trauma Pete. Like, you don't know Trauma Pete? So I'm a nurse for 15 years. I started my career at 16. I was an EMT. I worked on an ambulance part-time through my first undergrad degree during my nursing school. And I started nursing 15 years ago. I finished in 2010 out of a community college. And I did 3 years in our local emergency department, which I'm still at right now. And then I spent 4 years on our flight program, 4 helicopter, 2 critical care ground transport program for 4 years. And then this position here, this core trauma nurse here at our facility opened up about 8 years ago, right around when my kids were born. And the move in terms of ease of adjustment, childcare, day shift, matrix schedule kind of opened up. And I've always had a great deal of respect for some of the colleagues that came before me. I'd be remiss if I didn't mention, one of my mentors, which was Lori Cartwright, who's now a nurse anesthetist. And she was really kind of that person that I really looked up to when I first started. The program for us, core trauma at our facility, we're a level 1 adult, level 2 pediatric center. We do roughly about 1,500 trauma activations per year. We have a 3-bay trauma bay with a fully functioning OR within our trauma bay. So we can go straight to OR right off of an EMS litter. It's really an interesting place. It's a little different than a lot of places do it. Our trauma surgery team are the primary leader of our trauma activations within the space, augmented by anesthesia and emergency medicine as of recently. When I first started there, it was really just trauma surgery would run those trauma alerts. And it's been really amazing to watch the growth and the change over the years of that. I also work in a hospital. There's about 700 beds. We're a pretty large-scale teaching facility, so there's a huge opportunity for constant teaching, learning, education coming down the pipes from those colleagues. I work in probably one of the largest ERs in our region. I think we have 105 beds is actually the numbers, but if you really break it down, it's like 117 rooms. It's a very, very, very busy facility.
Wow. Yeah, sounds like it. That's a ton of beds and a ton of traumas in a year. Sounds like an awesome career. I am so privileged to have you talk on the podcast today. So let's dive into this case. Can you just set the stage? This was an atypical presentation of a pneumothorax. Can you just give us maybe the backstory? How does the patient present? What was the team told? What were you told whenever you became a part of this whole mix?
Yeah, so I was really kind of intermittently involved with this case. I was there on the patient's arrival. It was 60-year-old female coming from one of the northern tier areas whose daughter found her down with agonal respirations and started CPR on her. And so EMS got there. She was a GCS3. She wasn't really responding. I don't think they did any more CPR. I think she got some Narcan, didn't wake up. And then they ended up intubating her and transporting her down to us and was really, for the most part, hemodynamically stable on the way down, getting to us. So she arrives to us, intubated. She was GCS3. The vital signs were like grossly normal, like blood pressure 160 over 104, heart rate 107. She's 100%. Initially, kind of, that initial event transfer, 100% FiO2, afebrile, really not a whole lot. We start looking to her chart. She's got no encounters for the past 3 years. There's no meds listed on her history. She's not at other places. So it's kind of one of those people that probably doesn't go to the doctor on any regular basis.
So this is a pretty stable-ish post-arrest patient from the vital signs you're listing. I mean, I'm sure the team wasn't on high alert for pneumothorax for someone like this. Okay.
In my role as a core trauma nurse, I usually, if I'm not running trauma alerts, I have the ability to kind of be free, and I almost act as like a clinical resource on the floor. So intubated patients coming in is usually something that'll get my attention. You kind of come over, come help a little bit. You're looking for something to do. That's usually the spot to go hang out is in the critical care pod. So I was over in that area when this patient came in, and remember I spent 4 years on our flight crew. So I'm still friendly with a lot of the staff. And you always kind of learn something going to these cases as well. So I started getting involved with this case. I'm helping with looking up some of the patient's history. We're starting to get some meds on board. We obviously need to get an uric acid tube on her. We're going to try to get a Foley in her. We're going to try to get her undressed, get her presentable. She had some wet clothing on her. We wanted to get out of her. And that process of starting this patient in an emergency department in a non-trauma setting is quite drastically different than the way we would usually address our trauma alerts. Not only was this patient very hemodynamically stable, we're now essentially starting from scratch as to terms of what happened. Was this a cardiac event? Is it a medical event? Is it a non-compliance event? Is it a tox event? Your differential ends up being entirely different when it's just a found down patient versus, say, I know this patient was in a car accident. Obviously, you could have a patient who fell down a flight of stairs and had a cardiac event that caused him to pass out and fall down a flight of stairs. But the differential is entirely smaller with your trauma patients, in my opinion, than you do for your general population coming through the emergency department. Because of that, I think we still start really any of those cases on our ABC. So that's obviously airway, breathing, circulation. Tubes intact. We got good end-tidal waveform capnography right out of the get-go. Lung sounds are equal bilaterally, and she's got distal pulses throughout with a normal and marginalized blood pressure. So I don't think that initial insight and primary assessment that we were doing really changed anything. I do think we kind of did it in a very similar fashion. So, the patient kind of gets there right around 2:10, and I'm over in the room for about 30 minutes, kind of helping them get going. And then I get a trauma alert and I kind of take off, and so in the meantime, this patient gets over to CAT scan. They never get a chest x-ray right at her arrival. So you could say a couple of things. You didn't get the chest x-ray before going to CAT scan. Well, the patient was still stable. You have a stable patient, even with a pneumothorax, okay, maybe I have a higher risk of suspicion that we might have some problems down the road, which we're going to talk about a little bit here. But I think appropriate decision. I think we were really kind of focusing on whether or not her brain was having a problem. Stroke, ischemic versus hemorrhagic were pretty high in the differential, as well as seizures. And you really kind of wanted to get that global, generalized CAT scan of this patient. And so they took her to CAT scan, and guess what they found in the CAT scan? A large right-sided pneumothorax without tension etiology, which is kind of really interesting. And so they bring this patient back to the room, and they're going to put a pigtail catheter in her. They're kind of assuming that this pneumothorax was iatrogenic, most likely related to, the daughter doing CPR on her. And they start assembling a pigtail, and I'm coming back from this trauma alert now, and the charge nurse is kind of whispering in my ear, like, hey, they're getting ready to set up to do a chest tube over in that room. And I kind of walk over, they're starting to get some stuff. They're not ready yet. Boom, I get another trauma alert. So I kind of have to buck back out the door. I go back to another trauma alert. And then I come back. And in the meantime, what has happened at this point now is they've now placed the chest tube, and it's not looking so good. At about 16:37, now we're quite a while after she's arrived that they're now finally getting this chest tube in. But, 3 o'clock, that's the shift change. The doctors are changing. They're starting to report off. All you guys have had this problem where you can't get a hold of a doctor because they're reporting off, hey, we're just in rounds. We'll be right back. This was really what was going on. But this patient was stable. Blood pressures were normal. 160s, 140s, 130s, like 100% sats. Nothing's really changing. And then all of a sudden, she goes from a blood pressure of 130 to 98/69 at 16:30, and in 7 minutes, she's 64/55.
Ooh,
is her blood
fast.
pressure.
Okay.
Real fast, right? And this is literally while they're doing their first attempt at a pigtail chest tube. And short, rotund patient, a large amount of breast tissue. They attempt to get in pigtail. They get a great rush of air on the first attempt. They put it in, they hook it up to suction, go get a chest x-ray, and the lung's still down. The pigtail's placed in essentially like her lateral chest wall. So they need to get another chest tube. So I come into the room while they're attempting their second chest tube placement, and I look up on the screen and I see a blood pressure of 57/33 with a heart rate of 50. And they're starting Levophed for her hypotension now. And I had lots and lots and lots of questions coming in there. It was really interesting because in my role in something like that, it would really be a no question. I'm handing somebody a bottle of betadine and a scalpel's coming out of my pocket, and we're going to be doing, a finger thoracoscopy on a patient like this. And this is really where, to me, some of, at least my self-critique of this event was that I really should have called the trauma attending. And I called the trauma fellow because I was like, this is a medical patient. I shouldn't bother him with this. I'll get the senior. He's a 6-year surgical resident. Come on, this guy knows what's going on. And they kind of come over and help us after they attempt a second pigtail, get another chest x-ray. That doesn't go in. The fellow shows up. It takes us 5 attempts to get a chest tube in.
Oh my goodness.
And it's not until the third attempt where we finally get it optimally placed, where we go and do a repeat chest x-ray, and then we actually have lung re-expansion on that. And some of the interesting things is we did end up having a discussion, and a very kind of profound discussion, about doing a needle decompression on this patient, even after attempted pigtail placement, because they were like, oh, well, we decompressed her. We had a rush of air. And I remember thinking to myself, I'm like, no, we're still in tension etiology here, guys. This blood pressure is still 60, and you guys are giving her Levophed. We're not getting anything. It's because her heart is not pumping because there's too much air. So ultimately, we get a chest tube in her. And She ends up doing great. She ends up getting discharged from the hospital. Some of the chest x-ray reads that came down the pipe afterwards by radiology, I remember one saying, no tension etiology or subtle tension etiology visible on chest x-rays. So despite having...
But clinically, there's definitely some tension etiology, right? Interesting.
Hands down, it was unreal. She was hypoxic. Her sats dropped. She was hitting high pressures on the ventilator. Everything was right in front of us. And we all failed to recognize that this was a tension pneumothorax in front of us and we were suboptimally treating it.
Man. Okay, so hindsight wisdom is like the best teacher, at least in my experience. If you could go back to this case again, now that you know what you know, what would you have done differently as Trauma Pete in that room?
I had to call the big boss, the trauma attending, right out of the gate. That's probably the one thing that I regret is not doing is there should have been somebody to come in the room as the expert person to place a chest tube in an emergent situation. And I have the utmost respect for a lot of my emergency department colleagues, but when it comes to, having to crack a chest or doing a thoracotomy or slamming big chest tubes on a coding patient, I'm going to punt that down to my trauma attendings every day of the week. It's a really challenging situation. I get a lot of clinical respect from my physician colleagues as well as residents, mainly because, I'm the one in the Bay. Recently, one of our trauma attendings, we do this video review with the emergency residents. And this is his slide. Imagine it's a video playing of a 3-year-old dancing to music and the father standing behind her holding a hula hoop. And the girl's got a big smile on her face. And it looks like she's dancing and she thinks that she's hula hooping and the dad's just kind of holding it for her as she's trying to hula hoop. And the attending points to the little girl as the new resident and points to the dad holding the hula hoop as a core trauma nurse. And that's a lot of what we do is really like we're kind of the guys in the background. When they're struggling or they don't know where to go or we got multiple patients going on, either the core trauma nurses there or as the clinical resource experts in trauma in that bay and managing during those high stress environments. And so it makes it challenging sometimes for me because I have to make sure that I'm not stepping on people's toes. But when it comes to doing the right thing for patient care, sometimes I have to be a little bit more aggressive because it's a very fine line to walk.
Yes. Oh, I know the feeling. All right, Pete, I have so many questions and there's so many nuggets of wisdom from this particular case. I'm so glad you're willing to share it. Okay. First thing, I think at least as a nurse who's maybe just going down the post-ROS medical patient treatment, of course, the blood pressure drops, we're going to think norepinephrine, right? Let's get that norepinephrine going. That's the first line treatment for all shock states, except for this kind of shock, right? And so what do you think was going on there? Were they just not recognizing that this is tension etiology? This is obstructive shock and not some other source of shock? What do you think was happening there? How would you teach the bedside nurse who was so focused, or the team that was so focused on fixing the blood pressure with vasopressors when the source was that the heart didn't actually have space to fill, expand, et cetera?
There's a lot to unpack with that question. Let me start here.
Okay.
I think it's really important to understand some of the physiology behind where we get this development of a tension pneumothorax. And so really where my research going down this rabbit hole is the first question you need to ask is, what's this patient's ventilatory status?
Okay.
Now, a post-ROS patient, sometimes they're not intubated, right? They could be awake and talking to you. Maybe they're a little out of it, right? A lot of times I do think that they're intubated. You don't have a great neurological response. But we also get these other patients that come in that do have pneumothoraxes that are atraumatic or of unknown etiology, or they fell on a rock and they just got them hit in the right spot. They come in with a pneumo. Why don't those patients that are breathing on their own, why don't they clinically decompensate nearly as fast or as rapidly as these patients who are assisted? And what's the reasoning for that? So when you really kind of break it down, what we're thinking is really happening, you end up with this pleural defect and it kind of creates like a one-way valve. When you're breathing intrinsically, you're creating positive and negative pressure in there. So, imagine kind of putting a paper bag and cutting a hole in it and pushing in and out on that. That flap is going to kind of go opposite to the direction of the air. But then when conversely, you take a patient who's positive pressure ventilated via the ventilator or BiPAP, and you put that same pleural defect in, that flap now maintains in an open position because you're in a positive state for the entire timeline of that ventilatory, of your inspiratory and expiratory process. And so that patient ends up having a higher propensity for increased extrapleural pressure in the lung cavity. And at some point, it's unable to compensate for that anymore. And then you have this kind of drastic increase in pressure without having these other compensatory mechanisms. Now, in the unassisted patient, the patient who's breathing on their own, maybe they're on a nasal cannula or something like that, some of the theories is that you end up compensating for that with an increased respiratory rate, increased tidal volume, and then you end up with increased negative contralateral chest excursion. And you also end up with an incomplete transmission of pneumothorax-related pressure to the mediastinum and the contralateral hemithorax, and therefore it's preserving cardiac return via a venous siphon effect from increased negative contralateral intrathoracic pressure. So a lot to unload here, but what's really happening is your body is naturally saying, hey, I can figure this out. Like, let's kind of slow this down a little bit. And then you get a chest tube, you re-expand the lung, you're great to go. However, once you add in positive pressure ventilation to the mix of that conversation, all bets are lost. If you have a pneumothorax, you have a 17 times increased risk of cardiac arrest progression compared to the unassisted patient. It's staggering, the number. And not only that, it's the rate of which that progression of cardiac arrest occurs. And it's typically relayed in literature within minutes. And I see this in the trauma bay. You'll have a patient who comes in, you shoot a chest x-ray, and you see a little bit of a pneumothorax, and you're doing your stuff, and you're taking care of them, and all of a sudden, boom, they slam, and they're done, right? And that is just how fast these tension pneumothorax etiologies in the ventilated patient can crump, BiPAP, whatever it may be. A lot of times, even just a regular vented patient. But the other interesting part of that is the increased incidence of iatrogenic pneumothoraxes from stuff that we're doing. And what are the things that we're doing that we're not talking about? Subclavian line placement, IJ placement, lung biopsies, liver biopsies. Now, I would say there's quite a bit of elective procedures that do have a risk of pneumothorax. How many of them are ventilated? I know, say, for example, pacemaker insertions, they are going to be, ventilated, and you could have that risk associated with it. I don't necessarily work within that environment, but anytime you're putting a needle into someone's chest cavity, there's a risk of a pneumothorax. The rate of which a pneumothorax can progress to a tension pneumothorax is staggering.
So you bring up some good points. For those that aren't maybe as familiar with tension pneumothorax, I know it's so hard to describe in an audio format versus having like a marker board to draw it out. But can you just describe what's actually happening in a tension pneumothorax versus like a simple pneumothorax? Can you just differentiate the two?
Yeah, so a simple, uncomplicated pneumothorax, you're going to have the separation of your lung tissue off of the pleural lining of the inside of your wall. So your pleural tissue going off the pleural cavity, and then air gets in there and does a couple things. It prevents oxygenation of that tissue because it becomes collapsed and all the alveoli are completely collapsed. There could be some level of hypoxemia with it or some respiratory difficulty. We talked about a little bit those compensatory mechanism, increased respiratory rate, increased tidal volume to compensate for that lack of your VQ ratio type stuff. A tension pneumothorax, what happens is the volume of air within that pleural space becomes so great and increased in pressure that it compresses the pleural tissue of the lung in such a manner that it begins to shift that tissue to your mediastinum. And as it moves it across your mediastinum, what's in the way of your mediastinum? It's your cardiac silhouette. And so,
very important organ, yes.
And so when it starts pushing on that, it starts impeding venous return and preventing cardiac output. And I think really the big takeaway is that the lower pressure system in your heart is your vena cava, and it's easily compressible. And that high pressure compresses your vena cava, creates an obstructive shock, and then you have profound decreased cardiac output, and it's essentially a peri-arresting event.
For sure. Okay, so just to clarify, when we say tension physiology, we're not just saying, oh man, the sats are extra bad. Like the oxygen level, they're really hypoxic. What we're actually referring to is the lack of forward flow. Like the fact that the blood can't get in and can't move forward because the heart itself is actually being compressed because of the air that's in the wrong spot. So it's not just a respiratory situation here. This is a cardiac circulatory issue. And as you described, it happens really fast. They go from a blood pressure of 160 to 60 over 40 in a matter of minutes. So it's a very serious issue.
Yeah, in the 50s.
Okay, so let's talk about what is your approach to treating someone who has, say, a simple pneumothorax, which is what I think that they thought they were dealing with initially, which is a simple pneumothorax. Once it develops into a tension pneumothorax, like, what are we doing differently? What are our treatment options? Let's just put ourselves in the trauma bay. You're in the trauma bay with all the resources you need, all the needles, all the scalpels, all the betadine. All right. How are we treating simple versus tension?
Let's talk about our diagnostic capabilities that we use.
Okay.
I think, really at the forefront of technology right now is our ultrasounds. We talk about lung sliding, the barcode sign, the C-short sign. So the barcode sign and the C-short sign utilize the M mode, which is it sends a single phase into the lung tissue, and then it marches out across in a lateral viewpoint across your screen. And what it does is it shows you the chest wall tissue on the most inferior and the most top point of your screen. And then there's a kind of solid bright line mid-traversing it. And then on the bottom is a really kind of grainy view. And that grainy view is caused by your lung tissue physically moving while you're breathing in that area there. And on the top one, it kind of looks like waves. They kind of call it this is like the seashore sign here, right? That's normal lung sliding. You see a clear differentiations between intra and extrapleural area. And that's kind of what you're looking for. When you get to the barcode sign, everything that was extrapleural looks the same as it is intrapleural. And that's not a good thing because you kind of want those things to look different. And so, usually a barcode sign is more consistent with of a pneumothorax. Now, you can also use another method as well, which is lung sliding. And you're essentially looking for the ants marching is kind of what they call it. So that's the sliding of your pleural lining actually physically sliding as you're breathing, right? Remember, you have that surfactant in there in that tiny little space there that's promoting the sliding of your lung tissue against the inside lining of your pleural wall. And so they can see that in there. We won't necessarily slam down a chest tube, just you would need to usually have some other type of compromise, whether it be hypoxia or low blood pressure before we would do that. Now, chest x-rays, supine, at best are saying 50% sensitivity for that. Many times we've done chest x-rays, they look great. And then you take them to CAT scan, they got this big whopping thing there. Other diagnostic criteria or assessment criteria that I really kind of key on into, at least in my opinion, are like subcutaneous emphysema in the neck, in the armpit. You really got to get in there and push. And hypoxia is present about 50% of the time in the unassisted breathing patient, but it's about 91% of the time it's present in the assisted ventilatory status patient. So if you're seeing increased FiO2 demands on your patients as they come in, and you got, hey, the lung sounds don't sound really real great over here, or hey, maybe I'm a little hyper-resident over on this side here as well. Those are really some key clinical findings. Obviously the most definitive is CAT scan, but that takes time.
For a super critically ill patient with a terrible blood pressure to CT, no, I need to know the source of this problem right now. Oh, that's what I was going to say. I have had so many patients with a pneumothorax, and I heard lung sounds, and so did the provider.
All the time.
And so I feel like I was misled in nursing school, or even in my early days as the ER nurse, to think if you heard lung sounds, then you're good to go. There's no pneumo. But I don't know, probably 100 cases where I heard lung sounds and there actually was a little pneumo going on there. So that's not the best definitive diagnostic tool. Definitely we're going to need some sort of imaging, preferably CT like you said, but POCUS works great in the hands of the right clinician.
If we do have a notable chest x-ray that shows us with a pneumothorax, that patient, I would say 9 times out of 10 is going to get a chest tube. If we have a positive FAST exam, a chest x-ray that is not terribly significant or is not really leading us thinking that there's a pneumothorax, it's kind of provider dependent. If you see subtle signs like a deep sulcus sign, you see sub-Q air in your chest x-ray and you got a positive FAST, maybe a little low SATs or something like that, it's all really dependent. And I'm not going to say it's all the time and I'm not going to say it's never, but all those little subtle signs are usually little keys for me to say, okay, where's my equipment? What's the tools I need? What am I doing to prepare for this? Is this patient awake? Do I need to think about what kind of medication management do I want? How am I positioning this patient? Do I have equipment ready for conscious sedation? And all those little things are little kind of key takeaways that I'm going to take with myself when I'm taking care of these patients, looking in my environment as to what do I need to do next?
Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now wherever you get your podcast. Give it a listen. Now, back to the episode.
And Pete, I think that's like the difference of being the core trauma nurse who's done hundreds of these cases, is you are thinking 10 steps in advance. Like you have an inkling that there is a pneumothorax and you've already got like the 17 things you have to prepare for to respond if this is a pneumo. Versus I remember being a new grad, just being so task oriented. Like I had to wait till someone said, oh, it's a pneumo, we're going to place a chest tube. And then I'm like, okay, what's the next task in front of me? Rather than like the big picture, what am I trying to achieve? What's the worst case scenario? If this goes wrong, I'm ready for this. If this goes wrong, I'm ready for this. Okay, so let's kind of go down that path. Let's say you know this is a tension pneumo just based on vital signs and presentation. You don't even have imaging yet. You just have the gut feeling. What are the things that's going through Pete's head? What are you preparing for? What supplies you need? How are you positioning the patient? How are you supporting the resident who's doing their very first decompression? Like, what are you doing there? And then we'll transition and talk about a chest tube itself. Why do we do needle decompression? And then what are you preparing for to make sure this goes smoothly?
A couple things on needle decompression. There's kind of a couple pitfalls that we need to kind of talk about. One is your size. Standard IV catheters are about 1.8
inch and a half. Yeah.
Pretty small. Even what we use are ultrasound IV lines. I mean, they're only about 4.5 centimeters. Optimal length for needle decompression per the literature, 7 centimeters is the actual one. We don't even have them, but if you can believe there's not, I have 13 centimeter, 14 gauge IVs that we specifically stock in the trauma bay just for that reason that we transport the patient to CAT scan with. You know, we had a special order them. That was it's been something that in my career, we've done it a couple of times, but you have to have a judicious provider in terms of not slamming it all the way to the hub. As far as placement, we've been historically told the second ICS midclavicular line, data is really telling us now that, hey, maybe that mid-axillary line on your right side at your fourth intercostal space is actually better. You have to think about and be aware of body weight, chest wall thickness. But they were showing one study showed only successful needle thoracoscopy 40% of the time, and then had a failure rate of 50%. I mean, it happens, kinking it's flexible material. It's occluded by blood clots. The patient's moving. Did you push it down far enough? Did you go over big breasts or something like that? All those things add up. So one of the things I was taught when I was a flight nurse is if you put one in and you don't get the response, put a second one in. And this is really just meant to be the initial, see if we can improve the etiology of that tension pneumothorax etiology while we're trying to get our supplies prepared to transition to a full finger thoracoscopy or tube thoracoscopy. We're going to utilize a scalpel or some type of Sellinger technique for that.
Right. This is just buying us a couple more minutes. This is not like our definitive treatment. You got your needle in, you can go home now. There's a lot more to be done. I feel like in the movies, it's like this, they get the needle and they slam it in the chest and they're fixed. And everyone's like, woohoo, the patient wakes up and they're good to go. But in real life, this is just gives us a couple more minutes to prepare for the next treatment, which is going to be that chest tube. Okay. So real quick, pearls, pitfalls. What do you want people to know when preparing for positioning, doing this procedure? Then we'll move on to chest tubes.
I got a good one for you on positioning. So obviously a lot of our trauma patients are all lying flat on their back, but our awake patients is sometimes just sit them up. It's actually a little bit more comfortable for them if they're having trouble breathing. And I like to take their arm and kind of put it above their head. If I'm resource limited, I will usually grab a restraint and tie their wrist almost behind their head to the opposite side of the bed rail. And you ever get tickled on your side there? It's kind of a sensitive spot over there. And now we're gonna jab a needle in you, and your elbow's right next to the physician's head. And I think it's kind of a nice thing to prevent your physician from getting elbowed in the arm while they got a scalpel in their hand. The other fun one is if you got a medical student with you that you don't really like, you just say, hey, hold this person's arm over there for the next 20 minutes while we do this procedure. It's a really good one too. But you got to treat this like a conscious sedation. I think it's a rather barbaric procedure, and I think it's important that you make sure this patient gets some pain meds, some sedation. And so if you're going to be going down that rabbit hole of giving them a little whiff of Versed and a little whiff of fentanyl, you better make sure that you have your end-tidal waveform capnography going. You better make sure you have your cardiac leads on. You better make sure you have your alarms on for your pulse oximetry. And you might as well make sure that you have intubation supplies ready at hand with a person capable of doing an intubation.
Okay, very good. As far as positioning goes, do you do anything different positioning for needle decompression versus we're going to do the full chest tube?
No, I mean, really, it's the same thing. If we're going to be doing a needle
Right, especially we're going to go mid-axillary, yeah.
Yeah, you got to get that arm up. Probably the biggest pitfall with the lateral approach is your left side. Your cardiac structures are pretty close to you where we're going with that. And it's actually recent meta-analysis on the optimal needle length, also for ATLS and the European Trauma Council, actually suggested not even going on the lateral mid-axillary line approach on the left side and only sticking with the mid-clavicular line up at the second intercostal space on the left side, mainly because of the structure of the heart.
Okay. So just to clarify, if the space that needs to be decompressed is right side, going under the armpit is preferred. If the space needs to be decompressed is the left side, you're kind of in treacherous territory because the heart is so close and there's risk for additional injuries that we cause while we're trying to fix the patient. Okay. One more thing. Whenever I'm positioning patients, if they're awake, I often will tell them, all right, we're going to put your arm above your head like you're just relaxing on the beach. And to help you with this relaxing, I'm going to tie your wrist to the stretcher because I care. So just get as relaxed as you can in this position, and we will help you stay in this relaxed position while we fix your chest. All right, let's talk about chest tube placement. Okay, so let's say we got the needle in. Okay, things are getting better, and now we're preparing for the chest tube placement. Can you talk about the nurse's role in setting up for and kind of facilitating that whole thing going down?
We have specialty line carts in our regular department as well as in our trauma bay. And each of those line carts are stocked with supplies specific for this task. Like, this is why we have it set up. We have the Pleurovac boxes there. We have the 3-inch wide tape is there. We have abdominal dressings are in all the ER carts. And then we also have Vaseline gauze. And we have kind of all of our things there as well, in addition to, I guess they call them a rubber-tipped hard clamp, which is one of our policies. You have to have those 2 rubber-tipped clamps in the event of accidental tube migration that you can clamp the chest tube really fast. I have my own thoughts on that, but that's not neither here nor there. But the nurse's role is really just kind of anticipating the equipment needs, right? You're going to have to get a Pleurovac, and the Pleurovac is going to be dependent upon what your facility buys. You kind of really have 2 options, is a wet system and a dry system. We use a dry system. You still have to put water in it, but the nice part about it now is it comes in a pre-filled little bottle in the back of it. I mean, I can have a Pleurovac set up in 15 seconds and hand it off, and now I'm not done with that task. So previously, before that, you had to go grab a 100 ml bottle of water and sit there with a funnel and put it over the area of the Pleurovac that is the suction control, and fill it up to 20 centimeters of water for your suction. So these new systems are really great. They're really fast, nice, easy to set up. And then I'm just waiting there to make sure that it's hooked up to suction, I'm properly operating. And once they have that chest tube in, I'm going to hand off that end of that Pleurovac system to them, and they're going to connect it. And then having ready for them, suture, if they haven't already had those supplies ready to go, because they're going to suture that chest tube in there so where you don't migrate it, wrap some Vaseline around it. They're going to smack maybe a couple ABD dressings or some 4x4s over and then tape it down. And then from the nursing standpoint, we have to make sure that we're securing that connection between the chest tube and the Pleurovac. Now, that connection between the chest tube and the Pleurovac, typically tubing coming off the Pleurovac, I don't know if you've ever played with it, it's kind of like really spongy. It's kind of very flexible. That 5-in-1 connector that's connected to that, it's not going to come off of that thing. I mean, you got to sit there, like, I can bench press 315 pounds, but I'm telling you, I can barely pull off this little piece of plastic off of the end of that Pleurovac thing. And frankly, I don't. If I need to get rid of it, I cut it off because it's faster and easier. The problem where you're going to have that connection lapse is between the Pleurovac, that 501 adapter going into the chest tube that's rigid inside of your patient. And so you have to make sure that connection is really pushed in there tight. And then a lot of times I'll even tape down the flexible tubing of the Pleurovac down almost to where that patient's waist is, so that my patients in the trauma bay or the ER, they're not staying there. We're going somewhere with them. This is not their end destination. So they're going to be moved at least one time on the litter. In the trauma bay, that patient's going to be moved at a minimum, usually 3 times. They're going to get moved onto the CAT scan table. They're going to get moved off the CAT scan table, and they're going to get moved into a room, either in the emergency department or in our destination, whether it be the OR, the trauma neuro ICU, interventional radiology. It's a huge opportunity for migration of that tube. And whatever I can do to prevent that tube from migrating by yanking on it, pulling on it, kinking it, whatever, I'm going to take every available process I can do to prevent that.
So if I'm hearing you correctly, because I did the same thing. So not only are we secured at the insertion site, but you put an additional securing somewhere, usually like on the abdomen, so that if it gets tugged, we're tugging from the additional piece of tape you added, not from the source that we inserted this device.
Yeah.
Because it's the worst whenever it's not even you, right? Someone else like moves the side rail down. You have like a non-clinical person, a transporter or something helping you, and then like tugging this chest tube. It's only happened to me once and never again while it'll happen. I go extra on the tape to make sure that doesn't happen on my watch. Okay. So we get the chest tube in. Yes. Let's talk for a second about what we're looking at when we look at the chest tube collection canister, right? They're supposed to be titling in one column, which may or may not be there. And then there's the other little section that's measuring or giving us an insight to if there's any air leak. Now, sometimes an air leak is to be expected, but eventually we do not want to see air leak. So can you talk about what would you expect? And then how would you troubleshoot if you're still seeing an air leak?
We'll talk real quick about the areas. Usually, at least in our facility, the farmost right one is your drainage collection. And then somewhere else, there's another spot where it's got some water in there. That's going to be your water seal area. And then if it's a dry or wet system, you're going to have some area where it's going to control your level of suction. A wet system is going to utilize physical water, and a dry system is usually going to have a knob with some type of indicator that's going to tell you that suction is being appropriately applied to the device. So when I think about troubleshooting or going through that particular device, I usually like to really start at the patient. So one of the key things that we're looking for is an air leak in that system. And now in a patient with a known pneumothorax, we're assuming or we know that they have air in their pleural cavity. So when you apply suction to that system, you're going to get an air leak. So your initial time that you put this chest tube to this patient and the first time you apply suction, you should be anticipating to see some type of volume of air moving its way out of that system and out of that pleural cavity. So you should be expecting to see an air leak initially on placement of that. Now, the air leak is interesting because ours has like 5 or 6 graduated steps. If you completely disconnect that Pleurovac and put it to hold in your hand and turn the suction on, it's going to air leak to like level 6. It's going to fill the whole chamber. So if you walk into a room and you look at that air leak and it's blowing bubbles out the whole thing, immediate intervention is needed there. However, if you do a little bit of bubbling on your patient when they first come in, that's kind of expected. Usually what I'm doing when that patient comes in, we put that chest tube in. I'm going to kink the suction. I'm going to ask him to take a couple deep breaths. One, within that water seal area, there's usually a little ball that slides up and down during the device. And we refer to that as titling. And what it's really actually reflecting is the positive, negative pressure of that patient. So I'll say, hey, take a big breath if I can. It's not necessarily always diagnostic, but I can utilize it in my resource pocket of saying, oh, I got titling and I got like a little air leak kind of going on that's intermittent because of the positive and negative pressures of breathing. And so I can use those resource pearls to say, hey, I have a pretty good confidence interval that this guy's actually got the chest tube optimally placed. However, if all of a sudden you come out and you see like an air leak to 4, I got to try to start troubleshooting the system. And one of my colleagues told me a really good piece of advice when I was talking about some like tips and tricks from the core trauma nurse is that when you have a problem with equipment, or if you have a problem with a patient, start at the patient and move your way towards the equipment. So what I typically do is I'll start right literally at the insertion side of that chest tube. If it's taped up, I'm going to rip that tape off and I'm going to put a clamp right over that insertion site, right at that thing. Now, when I talk about seeing a giant air leak and I know that that chest tube is in and I clamp that chest tube, so I stop the suction of the chest tube going into the patient and that air leak stops, that means that air leak is most likely coming from inside the patient. And that's going to be my most critical event that I want to identify very early on. In the setting of trauma, that is typically a tracheobronchial tree injury. And that's going to be a really sick patient that you really need to push your team to identify because they're going to need operative intervention to fix that. And by doing that so early, I've kind of gotten rid of the most critical pitfall of not identifying where that air leak is coming from. Other areas for potential air leaks could be from the tubing itself. It could be from the connection between the physical chest tube to your Pleurovac setup, which is kind of connected by what looks like a 5-in-1 connector. As you start at that first spot right next to the patient, I'll clamp there. I'll say, okay, it's not this area of the chest tube. I'll go to where the chest tubes are connected at and I'll say on the chest tube, I'll clamp it right there and I'll evaluate whether or not that air leak is improved or not. If that air leak is still unchanged and the air leak is still going on, then I know it's somewhere between where I've clamped my clamp and towards the Pleurovac. So now I'm going to release the clamp again. I'm going to move past that connection. I'll clamp onto the physical tubing coming off that Pleurovac device. And I'm going to identify whether it was that connection piece between the two of them at that 5-in-1 connector. I found that sometimes is the source of the bubbling. I've also had other ones where we didn't recognize that someone either stepped on it or it got pinched when they were coming back from CAT scan, or it got inadvertently cut, but you really can't see it on some of that tubing, so it makes it hard. And so then you have to swap out that physical device. And then I've had other ones where you just got a crack in the Pleurovac chamber because they crashed it into the wall, but nobody realized that there was a crack in it in the back white of it. But as you troubleshot your device and started working from the patient back to the device, you were able to identify where that air leak was coming from and then swap it out as you moved away.
That's good. That's good advice. I wanted to tell you a quick story that just came to my mind when you were talking about troubleshooting the chest tube itself. When I was the ER nurse educator, a new grad had just gotten a patient from a smaller hospital that transferred to us. They had a simple pneumo, had a chest tube placed, and then shipped to us. And the nurse came out, but she's like, Sarah, my patient, I got a report that they were doing better. They're like really working to breathe now, and I don't know how to help them. They're saying they can't breathe. I was like, okay, let's go check it out. Let's troubleshoot together. So I go look at the Pleurovac. There's like no movement at all. There's no titling. There's no bubbling, which not the worst thing ever, right? But I'm like, can you take a deep breath for me? Can you cough? Like nothing. Okay, so then I'm like tracking it up. You know that little blue like clamp, like slide clamp that you can do to clamp the thing off? It was clamped. I think that someone thought that you have to clamp these for transport. I don't even know. But the patient told me, like, yeah, I was doing so much better at the other hospital, and now I can barely breathe. Yeah, so I just unclamped it, and then they had redeveloped their pneumo in transport from the other hospital. Anyways, and the new guy was like, how did you know to do that? I was like, honestly, I was not expecting that was the thing. I did not expect to find someone had clamped the patient with the pneumothorax chest tube. But they did, and we unclamped it, and they got better very quickly. So yeah, trace that thing back. It's a great way to figure out the source and hopefully treat it.
I got one that's going to beat that. I don't know if you're going to believe me on this one. I had a patient in the trauma bay, tension pneumothorax, gets a rapid chest tube. It goes in, it's kinked when it goes in. So when it goes into the fissure on his left side, it actually bends over itself. So like you shoot chest x-ray and you look at it and the chest tube's like bent in half, where it's like completely take a straw and bend it in half. That's what it looked like in there. And that does happen, frankly. It's not the first time I've seen it. But what happens is the provider goes and fixes it. And so she just takes that chest tube out, leaves it connected to the Pleurovac, and gets another chest tube, puts the new chest tube in, and then takes the previous chest tube that was in the patient that was bent in half, and then shoves it into the new chest tube that's into the patient now. Now, there's a lot of problems with that. But the problem is that there's large suction holes on those big chest tubes. And so I'm walking by the patient and I'm hearing this sucking sound. The blanket's over the guy. I pull the blanket off and I realize what they had done. And I'm like, and they're like, what do you need? I'm like, give me that. So now I have to rip off the secondary chest tube that's in the middle of the circuit now and rehook this thing up.
I was not expecting that's where the story was going. I was not certain they would have done. That is one way to do it. That's not the way I would have done it, but that is one way to do it. Oh my goodness. Very interesting. Okay. We've talked about a lot, Pete. Is there anything else you want us to know before we get into like the clinical pearls, the pitfalls, the things you want people to walk away from this episode with?
Iatrogenic pneumothorax, 70% barotrauma, progressing 41% of the time to attention pneumothorax etiology. So if you're on a vent and you have a barotrauma-related pneumothorax event, you have almost nearly half that patient population will progress to tension etiology. So if you have a sudden decompensation of a ventilated patient, tension pneumothorax has to be like number one etiology on your list. 13% of those are also from central line insertions. I couldn't find the data regarding what volume of those people progress to a tension pneumothorax, but put it this way, if someone's barotraumaed and ventilated and they're progressing that fast, think about how frequently a central line placement could happen on somebody who's intubated. Think about the populations that we're putting central lines in.
Those are the patients we're putting the central lines in, the ones that are highest risk for barotrauma. Okay, good points. Let's go through the clinical pearls. What I want to make sure people walk away with are the things that you are thinking when you are approaching these patients and the things that you have learned from the hindsight wisdom, the other people's mistakes, that you want to make sure that everyone walks away with that today as well. Okay, so take it away. What are the pearls you want people to know when it comes to pneumothorax and tension pneumothorax?
Have a high clinical index of suspicion post central line placement in a ventilated patient of acute decompensation as tension pneumothorax.
That's good.
Huge.
Any pearls as far as like chest tube setup, troubleshooting, critical thinking?
Knowing what your nursing process is when you're caring for this patient. The provider tells you that this patient has pneumothorax. What are the things that you have to do? One, you have to identify what is your patient's risk of decompensation. Are they breathing? Are they not breathing on their own? And have a high clinical index of urgency when a patient's not breathing on their own, because we know the frequency of when this can progress to a tension pneumothorax etiology. And each of those are going to take you down different pathways in terms of who do you need to call? Do you need more help? Do you need more equipment? Is the patient optimally positioned? Do you need medication management to assist in it? Does the patient need to get positioned? Have they been undressed yet? Do they need some oxygen? Do I need the airway cart? Do I need the code cart nearby? What other supplies do I need to have ready so that when the doctors are able to come in the room, we can get rocking and rolling right away?
All right, let's talk about pitfalls. What are some things that you want people to learn from your experiences and other people's mistakes as well? What should we not be doing? What should we be on the lookout for not to do when it comes to treating tension pneumothorax?
I don't think it's the not treating part. I think it's the actually treating it. And what I mean by that is you need to call the most senior person that you know when you have a problem like that. So someone called me and said, I need your help over here. And I came over, and the limitations of my practice prevent me from going and putting a chest tube in this person. And what I really should have done is I should have called the person I know is the biggest help in the setting of a tension pneumothorax, and that was the trauma attending for our facility. And that's what I should have done.
All right, that's good. So recognizing the tension pneumothorax type clinical presentation and then going down that pathway and not staying stuck on like, oh, it's just a simple pneumo. We're just going to put a little pigtail in. Like, no, like once you see that blood pressure tanking, once you see, I mean, usually you see tachycardia first, but you were seeing bradycardia. Okay, we know it's real extra bad now. We need to move quickly. So not waiting for imaging to confirm your diagnosis, but like looking at the clinical signs and acting quickly. Can you talk a little bit about some of the pitfalls with needle decompression?
Suboptimally placed short needles. You need to have an appropriate sized length, optimal being 7. If you don't have it or you don't know if you have it, figure out where you get one. We have a 14 gauge angiocath that's 4.5 centimeters in the top drawer of every single one of our code carts. And so I always kind of throw that fun fact out to new staff. And I'm like, you have a patient who's acutely decompensated. We need to decompress his chest. Where do you get the needle? And they're like, And it's a great opportunity to say, hey, why don't you come over to the code cart and let's run through the inventory of it real quick. Check this out. This is where this is at. Oh, hey, here's the line cart right next to it. Guess what else I got in here? Hey, do you know where a scalpel is? all these little tiny things of anticipating those equipment needs. I can't tell you how awesome I've looked before when an attending yells at the residents, hey, get that chest tube in 30 seconds. And I giggle and I put a bottle of Betadine on my desk and toss a scalpel in my pocket because in 30 seconds, they're screaming they want a scalpel and you hand them a scalpel and squirts of Betadine in their chest and they slam a chest tube in real fast. And you look like a straight up hero.
Like a ninja. Betadine scalpel. Yes, I do love that feeling, is having the supplies that I need and I can whip them out to support my team and ultimately my patient. I absolutely love that feeling. That's why I wear my ridiculous fanny pack, so I can be prepared for things like that. Well, Pete, I think we covered all the things we wanted to talk about today. This was a really great case. That's a good reminder how quickly tension pneumothorax can progress from a simple pneumothorax, especially in an intubated patient. Like, yes, they need to be intubated. They're post-arrest. They're not waking up. But we need to be aware that intubation, that positive pressure ventilation is going to escalate this thing real fast. So we need to be on the lookout for that. So thank you so much for your time. This was a great case to talk through. And I hope that people walk away feeling more equipped and prepared for their next tension pneumothorax that rolls in the door.
Yeah, great. Thank you so much for having me. It was a fun talk.
Yeah. Thank you, Pete.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.